real quickly, our next video, vascular access. We're going to talk about peripheral IVs, art line sticks, brachial and radial, and then an IJ central line. And as like I said, we got James here. He's SRNA. He's we're not going to let us. Well, he actually volunteered, but we're not going to do it. We're not going to put needles in him. I'll try to upload some videos of the actual needles going into the vessels. We're just going to show you like how to scan, how to get started, so you're comfortable with doing that. So you're not thinking about the little stuff when you're actually going in with your preceptor to learn these things. First things first, the ultrasound machine that we went over. We want to select the preset program that we want. We've got our L412T probe. I've got that selected, and I'll select vein. And see, it automatically drops my depth to 3 centimeters, and I'll actually usually, because I want to hit usually a pretty superficial vein that we're looking for, not the deeper, so I'll actually decrease the depth a little bit, and I might even increase the gain just a small amount there. For hand-eye coordination and ergonomics, I want the machine where I can see it without having to crank my head. So I don't want to be trying to put an IV in like this while I'm looking around my shoulder like this. You'll never get that done. So you want to look to where you got the monitor in front of you, so you can do your procedure while looking at your hand and the machine and have everything set up nicely. Once again, I like to put the ridge. Remember, the ridge always correlates with your GE, or if you're on a different machine, it's going to be a dot, ridge, something that correlates. If you don't have a ridge, you can just take your finger and do that and see how it's on the left side and left side. I want it, my left of my probe to correlate with the left of my screen. And that way I know which direction I need to move my needle. So if I'm in there, my needle, say I got a vein right here in the middle, and I put my needle in and it's over here, I know I've got to move it left. So I'm going to move to the left of my probe, which is the left of my screen. If I got that backwards, and I'll show you when we get to the IJ what I mean on that. But if I got it backwards, it's going to be very difficult, and kind of got to wrap your brain around it to make it happen. So oftentimes in anesthesia, we're called to place IVs when they can't get it otherwise. PIC's busy. You don't have PIC at your hospital, whatever, PIC team. I like to go for the antecubital area first. I know a lot of people don't like ACIVs, but in this situation, you got a patient that's going to be a difficult stick. They've already got multiple attempts. So we'll go here to the antecubital space, and there's a nice vein right there off the get-go. So what I want to do, you can see this little yellow arrow right there at the very top. That little yellow arrow correlates with my line here. The other thing, as I mentioned before, I can hit the MM button, and that'll give me a dashed line down through it, and I can line that up. I'm not going to hit it because it's really hard to see on video, but I can get that through it too. So I'm going to line it up just exactly center on my probe to start. Once again, my left's left, right's right. So I'll start my needle with about we'll say 22 to 45, probably a 35 degree or so angle. I might tilt my probe slightly towards myself, so I'll pick up that needle a little sooner when I go in, and I'm just barely going to pierce the skin under and hopefully see the little white dash of my needle there. And then I'm going to follow it in until the tip of my needle is right in the middle of my vessel. Once it's right in the middle of my vessel, I'm actually going to watch it slightly and slide my probe slightly, keeping the needle tip inside the vessel until I've got enough purchase so then I can slide my catheter in. But that's a good vein in the antecubital space there. If we come over here slightly, right here, we got an artery. Okay, what's the difference between a vein and an artery? So I'm pushing down. See how the vein easily collapses? It's compressible. I'm just pushing the probe down. I come over here to the artery, it's not collapsible. In patients you're having a lot of trouble getting a radial art line in, brachial art lines work great. We can come up here, it's usually a little bit bigger. There's a nice big vein on top there too, you can see. But you see they're very superficial. There's 1 centimeter depth coming across the arteries. The bottom of the artery is at 1 centimeter. So here's some tricks to figure out, okay, is that the artery? I'm pretty sure. If I really concentrate and look, I can see it pulsating. But it's kind of hard to say. See, so I can hit the color button, color mode, and circle it in, and boom. See the veins have a little bit of flow, and it's more stagnant. If I go over and circle it, you'll see maybe some flow. Watch what happens if I squeeze his forearm, though. Boom! All that blood in the forearm is pushing back up through that vein, so it's easy to identify it. If I do the same thing over the artery and squeeze, I get a little bit there, but it's probably more backflow, as you saw it, because it was blue. So I'll get pulsatile flow in there. Another thing I mentioned before, red's not always artery, blue's not always vein. So the arterial blood's flowing from his heart down to his hand. So I'm going to tilt my probe up towards his heart or towards his shoulder, and you notice it's red because blood is flowing towards that probe, so a red. If I tilt my probe away towards his hand, hey, it turned blue because now the blood's flowing away from the probe. So yet another way to determine whether you're looking at an artery or vein whenever you're getting things started. So for an arterial line, I'm going to do the exact same thing I did with the vein. I'm going to start dead middle, line up my yellow area with my yellow line or my line through if I've got the MM hit, turn the color off, and go for that. I'm in an out of plane approach, so I'm only going to see my needle going in as a dot like we showed you in the last video. I'll find that white dot. My white dot's a little bit to the right here. I'll move it a little bit to the left, and I'll just walk it down until I've punctured the artery wall. I'll slide my probe slightly to make sure it stays in the artery, and then I'll put my wire through and thread my catheter, and I got an arc line. I got enough glue on here. Obviously, the radial artery is another spot we do a lot of sticks, but look how much smaller it is down here. So there it is right there in the middle of the screen towards the top, about a half a centimeter deep, and it's quite a bit smaller, not compressible, but you got a lot smaller target to go for. I can kind of see it pulsating if I hold really still. I won't go through all the color changes with that, but same exact thing. You can just put it in like this. Probably, honestly, if I'm doing an arc line, I'm going to set my monitor away so I can look up like this ergonomically and place it in. Patients say the patient's probably going to have their arm out on an arm board in the OR, and I'll be sitting on or standing on one side of the arm board, have my monitor on the other side of the arm board to put it in. Okay. Okay, IJs are our main line in anesthesia. It's easy access to get to in a patient that's asleep. They're on our side of the drape, etc. That's usually our go-to. You can also do a subclavian central line with ultrasound, but we'll stick with the internal jugular today. So what I usually have my setup here is I'll push the bed out away from the wall. I stand at the patient's head, or if they're in the OR, stand at the patient's head. Put them in a little bit of Trendelenburg. We won't go through the whole process. We don't have a kit or anything like that. You can go through the kit. Mainly this is just the ultrasound visualization or access with it. I can actually, it's on vein, so I should be able to come over here and hit, where is that? No, maybe not. We'll skip it. There's a central line component over here. I'm going to make it a little bit deeper. We're still on vein, so I'm going to make it a little bit deeper. There we go. Get me a little more gel. My sterile field with all my tray components is going to be right here, so I can easily grab it. And then I put my ultrasound right at the end of it. Now, you know, most of the things we've talked about or we'll talk about, nerve blocks and everything like that, depending on the facility you work at, it's going to depend on basically how sterile you get with these procedures. Like an interscalene block, I don't use sterile gloves. I consider it like an IM injection that happens to be near some nerves. I do cleanse it with sterile prep solution. I wear gloves, not sterile gloves, and I place the catheter. The times when I consider things to become sterile is if I'm doing a nerve block and placing an indwelling catheter, like say I do an ESP block and I want to leave a catheter in for a few days, I'm going to do that sterilely. The central line is always going to be sterile for me. So I'll prep with sterile solution. There'll be a sleeve in your central line kit, or you'll have to grab it separately, and you'll lube up your probe and leave it here, and then have an assistant. You'll get your sleeve and hold it out, and the assistant will drop this into the sleeve, and you'll put it over, and then grab it, and boom, you're sterile again. That got Ryan over here. We got Brian film. Is that kind of you guys do too, as far as sterility for your blocks?
Yeah.
All right. So once again, I got my notch to the left. So I got the left side of the screen to the left side of the screen. And obviously I'm going to be working with my right hand, so I scan with my left. And right there is this internal jugular vein. Right below it's the carotid artery. Now what level am I going to stick? I'm going to scan up towards his ear. I'm going to come up towards his ear. Look, the carotid artery split. So I'm too high. I don't want to be up that high. So I'm going to come back down. Carotid artery comes together. I'm going to keep going even a little lower. Look how much bigger and nice that got. Okay, so that's probably the level I'm going to stick. It's a little bit below the level of the cricoids where I am there. Once again, I can apply some pressure. Vein goes away. I can ask James to hold his breath, bear down, and look at that. I get a super vein all of a sudden. You can relax now. get a super vein. I can go to my color again, and I can get my pulsatons. I gotta move my box. There we go. Tilted my probe down towards his heart, so now I get the pulsatile red flow of the blood coming from his heart up to his head, and I got my larger vessel here. That if I go down towards the heart, we're pumping blue because blood's going from his head back down to his heart, so it's going away from it. Or if I point it back up towards his ear, it becomes red. Those are all the ways I can verify, hey, that's the vein. The other way I can verify is because I know it's the great big one right next to the carotid on the outside, to the right side of it. But what happens if I flip my probe? And this is kind of what I was getting at before. If I flip my probe, oh, what happened? Did the IJ suddenly jump to the other side of the carotid? No, it's just a mirror image, right? So if I was in plane coming in from the side, now my needle would be coming in from left to right. If I flipped it correctly, now my needle is going to come in from the right to left. For me, that's more ergonomic. But we're not working in plane here. We're once again working out of plane. So what I'd do is if we come back down to the patient, I would take my local and I'd inject right, even with the line, because my line is right over the vein. And then I'd take my my needle that I'm going to do the central line with and go right through that. I'm going to poke through the skin, and then I'll come back up to the screen. I'll immediately see a big white dot. I'll watch that dot down until I'll actually see this tint in and puncture and pop in. And at that time, I can pull back and get blood into my syringe. At that point in time, I actually put my probe down, thread my wire in, and take it out. Then I'll pick my probe back up, and instead of seeing him in the out of plane view like this, I'll actually flip my probe and go in plane. So here's my IJ again. And I'll see a white or a metallic or hyperechoic line coming down through here like this. And that proves to me, oh yeah, my wire's definitely in that IJ space. And then I'll flip back and put my probe down and I'm done with it, and I'll finish my central line procedure. And that's basically utilization of the ultrasound for vascular access. IJ, arterial line punctures in 2 different places, and peripheral IVs.